I just start it like that? Great. Good afternoon, everyone. So we've had two great talks summarizing the recent advancements in breast cancer, and I've been charged with coming up with a few rapid-fire questions. You are going to reply using your cell phones, which you've done already this morning, so I know you know how to do it. I picked a few questions that are really more about the sorry, VK, but they're mostly metastatic because they were mostly from what came out of ASCO this year. So here's the first question. In Mona Lisa 7, the trial of endocrine therapy with or without ribociclib in premenopausal metastatic breast cancer patients, which of the following are true? This is the only study of CDK4/6 inhibitors exclusively in premenopausal women. B, I don't even know what 12 months means. That was not, sorry, I actually did look at this too. C is it's the first study of CDK4/6 inhibitors showing an overall survival benefit. And D is it's that first-line use of CDK4/6 inhibitors was superior to later-line use. And then E is everything, A, B, and C, but not D. So I don't remember what B was. I think it was that was what the difference was in progression-free survival. Okay, so I can stop this at any point. And so what you were supposed to say is which is true. And it's jumping around. I can't tell how many people have voted either. I can just see what the percent is. But I'm going to stop it right here. So it looks like we've got everything except A, which is that it was the only study of CDK4/6 inhibitors exclusively in premenopausal women, but it also was the first trial of CDK4/6 inhibitors to show an overall survival benefit. What it was not was a trial that compared first-line versus later-line use. And so just to review and go over that a little bit, this is the Mona Lisa 7 trial. It was only in premenopausal women. Everybody got their ovaries shut down. They could get either a nonsteroidal AI or tamoxifen, and it randomized between ribo and a placebo. It's the only study. Everything I italicized and put in yellow is one of your choices of questions. So it was the only study of CDK4/6 inhibitors exclusively in premenopausal women, but the other prior studies had premenopausal women that were able to enroll. So we've been using it in that setting based on those other studies. So I don't think this is really practice changing. And then this is the overall survival, which Mark has already shown you. It is the first study of a CDK4/6 inhibitor showing benefit for overall survival. But it was interesting. So only about 20% of patients in the placebo arm got later-line CDK4/6 inhibitor. So it was not a trial of should you give it first versus does it work to give it later. And so that would have been a correct answer. It was not a trial of first line versus later line. And then these are the subgroups. Mark showed you subgroups out of, I think it was the Paloma trial, but this is the subgroups, the forest plot out of Mona Lisa 7. And what's interesting, besides the fact that Asian women seem to do better, which you can't read that, but I'll tell you that's on there. I don't know why, from the addition of ribo. But if you look at only about 9% of patients in this study were 12 months or longer from stopping their adjuvant endocrine therapy. Most of the patients either recurred while the tumor was actively progressing on their adjuvant therapy or within the first 12 months. That's 90% of the patients had really just had a treatment failure with respect to whatever they were getting, tamoxifen and AI or whatever. So the group, let's see if I can get the pointer going. The group that was more than 12 months from the end of their adjuvant endocrine therapy really didn't seem to have any benefit from adding the ribociclib. I mean, the confidence intervals are wide and there's nothing statistical about it. But the groups that were, actively progressing at the time of recurrence while they were on an endocrine agent, or they had just finished it within the last 12 months, seemed to have a lot of the benefit. So this gets to the question, Mark, that you asked about, does everybody need a CDK4/6 inhibitor first line? And at least in this forest plot, the suggestion would be that if you've gone a long time off of your adjuvant endocrine therapy, that maybe you don't get as much benefit. That was not what you showed, though, in the Paloma trial. So we don't know is the real answer.
And I think the abemaciclib trial also looks similar to the Paloma 2 trial.
Yeah.
So this is kind of an outlier. But as you said, the confidence intervals are so
right.
wide.
I wouldn't make too much of it. So here's question number 2 on the SOLAR-1 trial, which was the trial of fulvestrant with or without alpelisib, the PI3 kinase inhibitor, in hormone receptor positive, HER2 negative advanced breast cancer. So which of the following are false now? That alpelisib added to fulvestrant had superior progression-free survival compared to fulvestrant with placebo, that patients were required to have at least one prior line of endocrine therapy and were required to have had prior CDK4/6 inhibitor exposure, that the benefit appeared to be limited to tumors with PIK3CA mutations, or that the side effects of alpelisib included hyperglycemia, nausea, decreased appetite, and rash. So which one is false? I'll let you vote for a little bit. So I will, everybody knows the side effects, obviously. I'm going to stop it here. And the correct answer, can I go back and show you that? The correct answer for which is false is B. Almost nobody had a prior CDK4/6 inhibitor in this study. So this does not tell you what the response would be if you've already had exposure to a CDK4/6 inhibitor. It is true that the benefit appeared to be limited to the patients who had PIK3CA mutations. So this is the SOLAR-1 trial, postmenopausal, metastatic, at least one hormonal therapy, and very few had prior CDK4/6 inhibitors. 60% of the patients in this trial had PIK3CA mutations. And it was a pre-planned analysis to look at the intent to treat and then those who had the PIK3CA mutations. Everybody got fulvestrant. They were randomized to alpelisib or not. And this shows you the response. This is progression-free survival for the PIK3CA mutants, 11 versus 5.7 months, very highly statistically significantly different, and there's no statistical significance in the PIK3CA normals. So progression-free survival was superior in the PIK3CA mutated cancers. That is part of the approval label, that you have to have a PIK3CA mutation. The most common side effects, you were right about that. You knew that wasn't false. And where, when, and how these drugs are going to fit in to the current treatment algorithms of metastatic breast cancer aren't clear, especially given that the patients in the study hadn't gotten prior CDK4/6 inhibitors. Okay, question number 3. In the NALA trial, which was the trial of neratinib plus capecitabine versus lapatinib plus capecitabine in metastatic HER2-positive breast cancer, which of the following is or are true? The neratinib arm showed statistically superior progression-free survival as well as overall survival, that grade 3/4 diarrhea was higher in the lapatinib arm, that capecitabine dosing was lower in the neratinib arm, or that progression-free survival was 6 months longer in the neratinib arm compared to the lapatinib arm. So what was true was that because of all the diarrhea, they went into this study by having the capecitabine dose at only 1,500 mg per meter squared versus 2,000 mg per meter squared in the lapatinib arm. So they knew they were going to run into major problems with diarrhea. So just note that if you are going to use this drug, that you don't start with standard dosing capecitabine. This trial looked at lower dosing. So the capecitabine dose was lower in the neratinib arm. This is the progression-free survival. This is the overall survival, which is not significant at this time, but the PFS is. But it's only about 2 months different. I think the question was it was 6 months different. Overall survival was not statistically significant. And then the diarrhea was worse, as Mark pointed out, in the arm that got the neratinib with the capecitabine, even though the capecitabine dose was lower. Okay, question 4. In the SOPHIA trial, which was margetuximab with chemo versus trastuzumab plus chemo, in patients who had already seen prior trastuzumab and chemo, which of the following is true? That margetuximab is a modified trastuzumab antibody with the FC portion engineered for more immune activation, that progression-free survival was statistically superior for the margetuximab arm, the toxicity was similar between margetuximab and trastuzumab, or D, all of the above. So you pretty much got it. It is all of the above. Margetuximab is a modified trastuzumab antibody.
It's trastuzumab-like. It's not actually trastuzumab. It's
I'll add a like in.
It's a chimeric antibody, and so it's got a completely different FC domain compared to trastuzumab. The HER2 binding domains are the same as trastuzumab, though.
Right. So thanks for correcting me there. It has the same signal disruption activity through the FAB portion, but as Mark says, the FC portion is really different and engineered for more immune activation. Remember, we actually don't know. We know for a fact that trastuzumab can work by shutting down the signal in HER2 and also through an immune networking way. And in a given patient, we don't know which is the predominant activity of trastuzumab. In any event, you pretty much got that one right. The toxicity was similar, except there was a little more infusion reaction with the margetuximab. And progression-free survival was statistically higher with margetuximab, although the difference was only 5.8 versus 4.9 months. And all of these patients had seen, prior trastuzumab. So not a whopping difference, but it is a difference, and I think we're going to explore what else should we do with the margetuximab, and could we give this with immune checkpoint inhibitors or vaccines or other things to rev up that immune activity of it. And then here we go. So this is the last question. In the Christine trial, which you didn't go over the updated data in the Christine trial. What?
I didn't think it was practice changing at this time, but.
Yeah, so the update was interesting, and I'll go over it, I guess. So in the Christine trial, which was neoadjuvant TDM1 with pertuzumab versus TCHP, docetaxel, carbo, trastuzumab, pertuzumab in early stage breast cancer, which of the following is false? That the PCR rate was higher for TCHP, that 7% of patients in the TDM1 pertuzumab arm progressed prior to surgery, the toxicity was less with TDM1 pertuzumab, that invasive disease-free survival was equal between the arms, or that pertuzumab has been shown to add efficacy to TDM1. So which is false? Okay, I'll stop it there. And what's false is that pertuzumab really hasn't been shown to add efficacy to TDM1, although every single trial being done with TDM1 now has pertuzumab added to it. And this is the Christine trial. It was actually published in 2018. We had a little update on it at ASCO this year. But basically, it's an idea that we're trying to de-escalate therapy in HER2-positive breast cancer because we're getting amazing responses and amazing, PCR rates. And so we're looking to see who doesn't need chemo, or at least conventional chemo, who can get away with less. And so this was TCHP versus TDM1 pertuzumab. And what was published last year was that TCHP was superior to TDM1 for the primary endpoint, which was PCR, 56% versus 44%. But important to note that 44% of patients had a PCR without conventional chemo. and that TDM1 pertuzumab had less toxicity, and that shouldn't surprise anyone. And then what we looked at in more detail in the final analysis at 36 months was, this is event-free survival, and this includes progression before surgery. And we had seen that that was actually better for TCHP. But when you look at that 6.7% of patients on the TDM1 pertuzumab arm actually had progression before surgery, and so they actually are thrown out of the study at that point. And what you end up seeing is that invasive disease-free survival is equal, but that's because it's only counting the patients that got to surgery and weren't thrown out of the trial. So if you're not one of the 7% who progresses before surgery, you do fine. So we just have to figure out who that 7% are that aren't going to do well. And that what they showed was data on HER2 heterogeneity and low HER2 expression that seemed to predict for that. And the point here is some HER2 positive patients likely don't need chemo, and pertuzumab probably doesn't add to TDM1. A metastatic trial, the Marianne trial, showed that. And I think that was my last question. Thank you.
Thank you. So we're eating into our break time, but perhaps if there's one or two questions, we can do those quickly.
This is a question to Dr. Gadi. We were discussing the data about early stage HER2 positive and the data regarding TDM1 to the Herceptin. Do you think that is if disease-free survival is good enough for us to start to use TDM1 in this setting, or we should wait for overall survival, especially in the adjuvant setting that we are talking about cure rather than metastatic?
That's a fair question. Obviously, the FDA has now approved this drug in that setting, and I think that's a pretty strong endorsement of using it. In terms of reasons not to use it, you do add a little bit of toxicity, of course, with TDM1 compared to trastuzumab. But over a period of 9 months, I think that's a reasonable trade-off to make, even without the overall survival data. The overall survival data trended. There was a 30% improvement. If you look at the hazard ratio, the p-value is not there. I'm not sure what more they'll be able to offer in the years to come, whether or not those curves meaningfully stay separated and there's a statistical significance to it. I actually, even without that, I think it's clinically meaningful already. And so personally, in my practice, I've made that change. I know Julie has. It's on our pathways at our institution. And I suspect it's the same where you are as well.
Interestingly, if you look at the actual distance between the Kaplan-Meier curves in the Catherine study, the point estimates on the percentages at about year 3 are identical to those in the original adjuvant trastuzumab joint analysis trial. So if you were impressed by the original adjuvant trastuzumab data in 2005, then you would be equally impressed by the Catherine data because the numbers are like overlapping, interestingly, though different patient populations to be sure.
And I didn't talk about it today, and I'm hopeful that we'll see this in the coming year. But we will likely have some evidence for using TDM1 in place of Taxol and Herceptin in small node-negative cancers as the TEMP trial data is being put together and wrapped up. So I think the TDM1 molecule will have potentially even more usage in this adjuvant space than we see it right now.
Yep. So VK, I have a question for you. So right as we were all going to ASCO, ASCO came out with an updated clinical practice guideline on chemotherapy in ER-positive breast cancer that basically said they actually moved the recurrence score assay up to 30, saying that less than 30 that you could consider chemo or not, and above 30, it was based on a lot of expert opinion. And then that also was before we saw the presentation of the Taylor-X kind of reanalysis. I mean, I know you're a MammaPrint kind of guy too, but we have this new ASCO guideline saying at least for postmenopausal women, you even with a recurrence score of 30, you don't even necessarily need to give chemo. You know, how are you taking all of this into account?
I have a hard time with this because a lot of these are secondary analysis. They were not pre-planned, and in general, if you're a purist, and I'm not necessarily that, in fact, I'm far from it most of the time. I think you treat the patient in front of you. But if you have low clinical risk disease, I would be, and I did order an oncotype, which I generally don't, I think there's still fudge room. So if there's a guideline that endorses with low clinical risk, even in a postmenopausal woman up to 30, it's a discussion you can have with that patient. I still think the trial data is the data. If I have that data and it says at 25 and above, we're supposed to give chemo, I still have to discuss that with that postmenopausal patient if she's low risk. And keep in mind in TAILOR-X, the patients with 6-millimeter tumors were offered chemotherapy based on a high-risk score. And the Mammoprint trial data that shows that that group really didn't benefit from chemotherapy. Their clinical risk was low enough that their outcomes were pretty much indistinguishable whether or not they got chemotherapy or not. So there's multiple data points that you could look to from phase 3 randomized studies prospectively that will give you a different answer. So at the end of the day, I think you sit with your patient and say, this is what we know, and you do or don't recommend it based on that.
I'd like to thank all the panelists. We're kind of out of time. Do you want to extend the break a little bit?